My name is Johanna Ramirez and I'm going to talk about treatment of highly drug-resistant pulmonary tuberculosis. Definition. Pulmonary tuberculosis is a contagious airborne infection that destroys body tissue. This occurs when Mycobacterium tuberculosis mainly attacks the lungs. However, it can spread from there to other organs. Pulmonary tuberculosis is curable with early diagnosis and treatment with antibiotics.
Or TB, is one of the oldest and most common infectious diseases. About one-third of the world population is believed to be infected with TB. Fortunately, only about 5% of these infections progress to active disease. The other 95% of infected people are said to have a dormant or latent infection. They do not develop any symptoms and do not transmit the disease. Tuberculosis is caused by a rod-shaped bacterium, or a bacillus, called Mycobacterium tuberculosis. An infection is initiated following inhalation of mycobacteria present in aerosol droplets, discharged into the atmosphere by a person with an active infection. The transmission process is very efficient, as these droplets can persist in the atmosphere for several hours and the infectious dose is very low. Less than 10 bacilli are needed to start the infection. Once in the lung, the bacteria meet with the body's first-line defense, the macrophages. The bacteria are ingested by the macrophages, but manage to survive inside. Internalization of the bacilli triggers an inflammatory response that brings other defensive cells to the area. Together, these cells form a mass of tissue, called a granuloma, characteristic of the disease. In its early stage, the granuloma has a core of infected macrophages enclosed by other cells of the immune system. As cellular immunity develops, macrophages loaded with bacteria are killed, resulting in the formation of the caseous center of the granuloma. The bacteria become dormant, but may remain alive for decades. This enclosed infection is referred to as latent tuberculosis and may persist throughout a person's life without causing any symptoms. The strength of the body's immune response determines whether an infection is arrested here or progresses to the next stage. In healthy people, the infection may be stopped permanently at this point. The granulomas subsequently heal, leaving small calcified lesions. On the other hand, if the immune system is compromised by immunosuppressive drugs, HIV infections, malnutrition, aging, or other factors, the bacteria can be reactivated, replicate, escape from the granuloma, and spread to other parts of the lungs, causing active pulmonary tuberculosis. This reactivation may occur months or even years after the initial infection. In some cases, the bacteria may also spread to other organs of the body via the lymphatic system or the bloodstream. This widespread form of TB disease, called disseminated TB or miliary TB, occurs most commonly in the very young, the very old, and those with HIV infections.
Applications in nursing. The activity of the nursing professional, which consists of direct care of the person with tuberculosis and their relatives, developing a control and monitoring plan for each patient, monitoring the appearance of adverse reactions to anti-tuberculosis drugs. We must also inform, educate, and guide the patient and her family about the disease. Follow-up of patients with drug-resistant tuberculosis. Pros and cons. Pros. In most of the cases, tuberculosis is treatable and curable. Cons. People with tuberculosis can die if they don't receive proper treatment. Drug-resistant tuberculosis sometimes occurs when bacteria become resistant to the drugs used to treat it. This means that the drugs can no longer kill the TB bacteria.
Multidrug-resistant tuberculosis, resistant to isoniazid and rifampin, is diagnosed in almost 500,000 new people each year. The World Health Organization recommends a 20-month treatment course, but cohort studies in Bangladesh have shown promising results in multidrug-resistant tuberculosis using shorter regimens. This randomized non-inferiority trial of participants with rifampin-resistant TB susceptible to fluoroquinolones and aminoglycosides compared a 9 to 11-month course of treatment containing high-dose moxifloxacin, the short regimen, with the WHO recommended 20-month course of treatment, the long regimen. The primary outcome, or favorable outcome, was defined as culture negativity during treatment and at 132 weeks post-randomization without an intervening positive culture or unfavorable outcome. An unfavorable outcome was defined as starting 2 or more drugs not in the allocated regimen, treatment extension beyond the permitted duration, death from any cause, a positive culture result when last seen, or not seen at 76 weeks or later. In a modified intention-to-treat analysis, 78.8% of those in the short regimen group had a favorable outcome, as compared with 79.8% of those in the long regimen group, for an HIV-adjusted difference of 1 percentage point. The 95% confidence interval did not exceed the 10 percentage point margin of non-inferiority. Both regimens had a similar frequency of severe adverse events. An increased corrected QT interval developed more frequently in patients on the short regimen. The authors conclude that in patients with MDR-TB susceptible to fluoroquinolones or aminoglycosides, a short 9 to 11-month regimen had non-inferior efficacy and comparable safety to the WHO-recommended longer regimen.
Agent applied in Ecuador. In 2015, the estimate by the World Health Organization for Ecuador was 8,400 new cases of TB, including those with TB HIV co-infection. However, the national health system, comprising the Comprehensive Public Health Network and the Complementary Tuberculosis Prevention, Diagnosis, Treatment and Control Network, diagnosed and reported 5,250 cases, fulfilling 62.08% of the estimate. Of the notified cases, 5,9,700 correspond to cases unrelated and 118 previously treated cases. Finally, pulmonary tuberculosis is a contagious infection. It can be curable with an early diagnosis and treatment with antibiotics. In order to understand the spread of extensively drug-resistant tuberculosis in Ecuador, increased efforts are needed to evaluate resistance to second-line anti-tuberculosis drugs. For this purpose, it is necessary to expand testing services to detect cases in a short time and involve the community to ensure that patients are tested and take the drugs regularly.